Med history. Cholera is a dangerous anthraponotic infectious disease that proceeds according to the type of gastroenteritis with intoxication and violation of water electrolyte metabolism, leading to severe dehydration of the body. Cholera refers to quarantine infections. Cholera is characterized by a fecal-oral mechanism of infection, damage to the small intestine, a pronounced tendency to widespread epidemic spread, severe course with watery diarrhea and vomiting, the development of various degrees of dehydration, and high mortality. Cholera has been known since time immemorial. It's described in the writings of Hippocrates, Greek, cholera, the outflow of body fluids from chole bile, rio, to flow, to expire. According to available data, the first scientific description of the cholera epidemic was made in 1563 by the Portuguese physician Garcia del Huerto in India. India is considered to be the historical homeland of cholera, where epidemics of this disease were noted as early as 500 years BC. The long-term preservation and reproduction of the cholera pathogen is facilitated by the climatic conditions of India. The average annual air temperature favorable for the pathogen is 25 to 29 degrees Celsius, abundance of precipitation, swampiness of the area, a large amount of organic substances in the water as a result of continuous pollution of rivers with sewage and excrement, high population density, low material standard of living, and peculiar religious and cult rituals. There are 4 periods in the history of the spread and study of cholera. The first period covers the period from ancient times to 1817. At that time, cholera in the form of epidemics was recorded only in Southeast Asia, mainly in India, and did not go beyond its borders. The second period covers 1817 to 1926. At that time, cholera spread across all continents in the form of 6 pandemics that killed millions of human lives. Therefore, cholera was depicted in the image of death, mowing down sick people. In 1823, cholera entered Russia, and in 1830 to 1831 into Europe. The penetration of cholera into Europe occurred through the Middle East, Egypt, and the ports of the Mediterranean. During the second period, the etiology and main epidemiological features of this disease were studied. In particular, the English doctor D. Snow, in the study of the cholera outbreak in London in 1854, he suggested and justified the waterway of transmission of the pathogen of the disease by drinking contaminated water from the River Thames and columns. From 1961 to 1996, people were ill with cholera in 146 countries. Persistent endemic cholera outbreaks have formed in Southeast Asia and African countries. Thus, in 2003, large outbreaks of cholera were noted in Liberia, 33,604 patients, Congo, 22,768 patients, Mozambique, 13,758 patients, Somalia, 4,877 patients. In 2010, a major outbreak of cholera was reported in Haiti. According to WHO, in recent years, from 3 to 5 million cases of cholera have been registered annually in the world, including 130,000 fatal cases. High morbidity and mortality are observed mainly in developing countries. V. cholerae is a curved, short, movable sticks. The cell sizes of Vibrio cholera are 1.5, 4, 0x0, 2, 0.6 microns. Polymorphism is characteristic of cholera vibrians. Typical curved shapes are found in the clinical material, and straight rod-shaped shapes predominate in preparations from nutrient media. Cholera vibrians are facultative anaerobes, but prefer aerobic growing conditions. The optimal cultivation temperature is 37 degrees Celsius. Cholera vibrians belong to the group alkali-loving microorganisms. They grow well on simple nutrient media with a high pH value, 7.6, 8.2. This property is used in the selection of nutrient media for the cultivation of cholera microbe. Elective nutrient media for the cultivation of Vibrio cholera are alkaline MPA, TSVS agar, nutrient agar with sodium thiosulfate, citrate, bromothymol blue and sucrose, SEDEH medium, dry electrodifferential medium for isolation of cholera vibrio, or CDHM, modernized SAG medium, Monsour medium, toroholate tellurite agar with gelatin. The composition of the nutrient media used for the cultivation of Vibrio cholera is presented in Appendix Num 1. Alkaline MPA is most often used, on which the cholera vibrio forms around smooth, vitreous, transparent colonies with a bluish tinge and weak opalescence of a viscous S-shaped consistency. Cholera is a typical anthraponotic infection. The natural reservoir is polluted water. The source of infection is a sick person from the first days of the disease and a bacterial carrier. Both patients with a typical form of cholera and patients with erased subclinical and atypical forms of the disease, as well as convalescences after the typical or subclinical form of cholera, convalescent vibrators. In cholera, the so-called iceberg phenomenon occurs when up to 100 carriers per one patient. The course of cholera can be typical or atypical. The typical course of the disease, depending on the degree of dehydration of the body, can occur in mild form. Dehydration is up to 3% of body weight. Moderate form, dehydration is 4-6% of body weight. Severe form, dehydration is 7-9% of body weight. And extremely severe form, dehydration is over 9% of body weight bodies. In 80-90% of cases, cholera occurs in mild or moderate form. An atypical course of cholera can occur in an erased in the form of hemorrhagic or dry, without diarrhea cholera. In less than 20% of cases, typical cholera develops with signs of moderate or severe dehydration. The incubation period for cholera varies from several hours to 6 days, most often 1-2 days. In the first period of the disease, mild cholera enteritis, against the background of normal temperature, rare loose stools and vomiting are noted. The patient's well-being is satisfactory. Patients complain of dry mouth, thirst, and muscle weakness. The disease lasts 1-2 days. In the second period of the disease, moderate severity acute gastroenteritis, there is frequent vomiting, rumbling in the abdomen, frequent stools, 15-20 times a day, which gradually loses its fecal character and takes the form of rice broth, a cloudy liquid with epithelial cells and mucus floating in it. The pathogenesis of cholera. The entrance gate of infection in cholera is the digestive tract. Once in the human body, a significant part of the vibrions die in the stomach under the action of hydrochloric acid. The remaining part of the pathogen reaches a thin intestines, the alkaline environment of which is favorable for the reproduction of cholera vibrio. Cholera is a non-invasive infection, since vibrions are localized on the surface of the mucous membrane and in the lumen of the small intestine, without penetrating into enterocytes. But enterocytes of the small intestine are a target for cholera exotoxin. To reach the target cells, the cholera vibrio must overcome the mucus layer on the surface of the enterocytes. Overcoming this barrier is facilitated by the mobility of the pathogen, its ability to chemotaxis, the formation of hemagglutinin protease and mucinase. Hemagglutinin protease causes agglutination of erythrocytes, cleaves fibronectin, and the cholera toxin subunit A cleaves vibrions from the surface of enterocytes, contributing to the spread of bacteria through the intestine and excretion with feces. Having overcome the mucus layer on the surface of the small intestine, cholera vibrions attach to the mucous membrane by means of toxin-regulated pili. After adhesion, the pathogen loses mobility and multiplies intensively, forming peculiar colonies in the form of plaques on the surface of enterocytes and causing colonization of the intestinal epithelium. Multiplying on the mucous membrane of the small intestine, cholera vibrio produces an exotoxin, which binds with component B to GM, one receptors located on the outer membrane of enterocytes. Neuraminidase, cleaving sialic acid from the GM1 receptor, promotes the strong binding of the exotoxin component B to the surface of the enterocyte. Then component A penetrates into the cytoplasm of the cell by endocytosis and releases the active fragment A1 under the action of intracellular enzymes. This fragment, it interacts with protein G localized on the inner surface of the cell membrane and eliminates its inhibitory effect on adenylate cyclase. As a result of successive reactions, CAMP is formed in the cell. The accumulation of a large amount of CAMP disrupts the function of the transmembrane electrolyte pump in enterocytes. Channels open for the release of chlorine, sodium, potassium, bicarbonate ions, and water into the intestinal lumen. Violation of the introductory salt balance leads to vomiting and diarrhea, in which the body loses up to 2 liters of water per hour. With 1 liter of bowel movements, the body loses 5 g of chloride sodium, 4 g of sodium bicarbonate, 1 g of potassium chloride. The volume of bowel movements can reach 20-30 liters per day. As a result, dehydration of the body occurs. At the same time, the stool acquires a characteristic consistency of rice broth due to the presence of intestinal epithelial cells in the saline solution. Loss of water and electrolytes leads to the development of severe dehydration, shock as a result of hypovolemia, hypokalemia, and metabolic acidosis, seizures, cholera algiid, intestinal paresis. Vibrio cholera endotoxin affects arachidonic acid. It is part of the phospholipids of cell membranes. As a result, prostaglandins are synthesized, which cause contraction of the smooth muscles of the small intestine and cause tenesmus. Diagnostic tests for cholera are carried out in specialized laboratories that have permission to work with the cholera pathogen. The main method of diagnosing cholera is bacteriological. The materials for the study are feces, vomit, bile, sectional material, fragments of the small intestine and gallbladder, bed linen and underwear contaminated with feces, water, sludge, sewage, hydrobionts, flushes from environmental objects, food products. Bowel movements are examined to identify bacterial carrier. Feces are taken away rubber catheters, glass tubes with fused edges, or rectal tampons. Of the objects of the external environment, the water of open reservoirs and wastewater are most often examined. Post-infectious immunity in cholera is short-lived. Immunity is antitoxic and antimicrobial in nature due to antibodies, immune memory cells, and phagocytes. At the same time, antitoxic antibodies, they persist in the body longer than antimicrobial antibodies. In patients with cholera, specific antibodies are detected 5-7 days after the onset of the disease. The main role in immunity against cholera belongs to antibodies produced locally on the intestinal mucosa. Antimicrobial immunoglobulins. Of the mucous membranes block ligands on the surface of microbial cells and prevent vibrions from adhering to enterocytes. As a result, the ability of cholera vibrions to adhere and colonize decreases, which leads to rapid elimination of the pathogen from the body during intestinal peristalsis. Antitoxic antibodies interact with the B subunit of the exotoxin, as a result of which they block the binding of collagen to the GM1 receptor on the surface of enterocytes. Treatment of cholera. If cholera is suspected, patients are hospitalized in a specialized department. Treatment of cholera patients should begin with the restoration of normal water-salt metabolism, symptomatic treatment. For this purpose, it is recommended to use salt solutions containing sodium chloride, sodium bicarbonate, glucose. Fluids are administered both orally and parenterally, intravenously. The amount of saline solution injected is determined using special formulas taking into account the relative plasma density and concentration. There's potassium in it. Fluid loss is determined by collecting vomit and feces in a special measuring dish. For this, the patient is placed on a so-called Phillips cholera bed, which has an opening at the level of the patient's buttocks, and the patient is transported on a special stretcher. Cholera prevention consists of nonspecific and specific measures. Measures of nonspecific prevention of cholera include sanitary and hygienic measures to prevent the introduction of the disease, sanitary and educational work among the population, early detection of patients and bacterial carriers, quarantine measures. Special attention is paid to the supply of high-quality drinking water to the population, chlorination of water, compliance with sanitary and hygienic conditions at food enterprises, in children's institutions and public places. Strict bacteriological control of water in open reservoirs is carried out. Emergency prevention of cholera is carried out by mass prophylactic administration of tetracycline in areas of epidemic danger. Other antibiotics effective against V are used for the same purpose. Cholera.